The gluteus maximus muscle has its proximal attachment on the ilium posterior to the posterior gluteal line. It's also attached at the dorsal surface of the sacrum and coccyx and at the sacrotuberous ligament. Its distal attachment ends in the iliotibial tract that inserts into the lateral condyle of the tibia. Some fibers insert on the gluteal tuberosity of the femur. The semitendinosus muscle and semimembranosus muscle have a similar proximal attachment at the ischial tuberosity. The distal attachment for the semitendinosus muscle is the medial surface of the superior part of the tibia, whereas the semimembranosus muscle has a distal attachment at the posterior part of the medial condyle of the tibia. The last muscle in the posterior section of the leg is the biceps femoris muscle. The long head has a proximal attachment at the ischial tuberosity. The short head has its proximal attachment at the linea aspera and lateral supracondylar line of the femur. The distal attachment is at the lateral side of the head of the fibula. The lateral compartment of the thigh contains the gluteus medius muscle and the tensor fasciae latae muscle. The gluteus medius muscle has its proximal attachment on the external surface of the ilium between the anterior and posterior gluteal lines. Its distal attachment is the lateral surface of the greater trochanter of the femur. The tensor fasciae latae muscle has its proximal attachment on the anterior superior iliac spine and the anterior part of the iliac crest. Its distal attachment is the iliotibial tract that attaches down to the lateral condyle of the tibia. In order to identify the location and path of the sciatic nerve, we first have to find the sacrum, then the greater trochanter, and last the ischial tuberosity. Since the sciatic nerve runs through the greater sciatic foramen inferior to the piriformis, the best way to locate it is to palpate between the greater trochanter and the ischial tuberosity. It then descends along the posterior aspect of the thigh and divides proximal to the knee into the tibial and common fibular nerves.
Range of motion of the hip joint. Flexion. Active flexion. Bring the knees to the chest. Place your hand on the back and the lumbar. Bring the knees to the chest all the way. Make sure the lumbar is flat. Bring it down. Abduction. Abduction. Bring the leg towards me. Make sure to kind of check the stability of the pelvis. Adduction. Adduction. Make sure that pelvis is not tilted. Bring the knee in a 90 degree, hip 90 degree. Ask the patient to bring the knee in, foot out, internal rotation. Bring the foot in, knee out, external rotation, active. Patient lay on the right side down. Hip joint, active extension. Make sure to stabilize the hip. Come back towards me, active. You can also do abduction on the sideline. Ask the patient, bring the foot up, abduction. Bring it down. Now, ask the patient lay on the back. Passive range of motion. Bring the knee to the chest. Patient relaxed. Place your hand on the back, right on the lumbar. Make sure the lumbar is flat. Bring the knee to the chest, all the way. Until either pain or discomfort or there's a limited range of motion. Make sure to do the appropriate draping. abduction, passive, abduction. Make sure to stabilize the hip, bring the foot out. Adduction, adduction, bring the foot in, passive. Good. Bring the knee up 90 degree. Internal rotation of the hip joint. External rotation of the hip joint. Passive. Now ask the patient, lay on the right side down. Extension of the hip joint. Stabilize the hip. Also, you can do passive abduction. Patient relax,